Well, thank you for the opportunity to present today's topic, Improvements for Breast Cancer Imaging, CEST MRI, and DCE MRI. I'd like to thank Bing Wu and the organizers for the opportunity to join you today to discuss these two topics. I'm Marty Pagel. I'm a professor in the Department of Cancer Systems Imaging at the MD Anderson. I'd like to first list my conflicts of interest. I work with a number of companies, our collaborators at a number of academic sites, and our funding sources. So chemical exchange saturation transfer, or CEST MRI, has been developed during the last 20 years and has finally made it to clinical studies, particularly for breast cancer, also for brain cancer, and some other cancer types as well. I'd like to describe how this method works because it gives insights into why it is important for the study of cancer. So this is a molecule, iopamidol, that is a CT agent, clinically approved, used thousands of times per day. So a very safe contrast agent. And we have repurposed this contrast agent for CEST MRI. It has amide protons, NH amide protons that exchange with water, and they have unusual chemical shifts because of their proximity to a ring in the center of the molecule. Because of these unusual chemical shifts at 5.6 and 4.2 ppm, we can detect this molecule using CEST MRI in a unique way. So we put this molecule inside the inner tube in this image, and then we put the inner tube within an outer tube that does not have the contrast agent. Now, if I were to selectively saturate at a frequency of 15 ppm, well, you can see that the inner tube has 100% water signal relative to the outer tube. And so I've put a small dot on this graph right here. If I were to then iteratively saturate at different frequencies, well, the water signal in the inner tube is about the same as the outer tube until we reach 5.6 ppm, where clearly the selective saturation of the proton at 5.6 ppm is causing that magnetization to become incoherent, and then through chemical exchange to water, that incoherent MR signal is transferred to the water, and the water signal looks like it is darker within that inner tube relative to the outer tube. Now I'm going to play the next part of this movie, and you can watch this inner tube. It will get brighter and then darker as we saturate from 5.6 to 4.2 ppm. And you can see another peak is appearing within this so-called Z spectrum or CEST spectrum. And if I were to continue, the tube does get brighter, and then both peaks get dark as I am selectively saturating the water directly at the water frequency. So even the outer tube is dark in this case. And then for analysis purposes, the CEST spectra are often taken in a symmetrical way. And in this particular case, we fit the CEST spectrum with Lorentzian lines to show the CEST peaks at 5.6 and 4.2 ppm. So this is a molecular imaging method able to directly detect or indirectly detect molecules based upon the water signal after the saturation transfer through chemical exchange. So this chart below shows the types of CEST agents or CEST molecules that are typically used. There are paramagnetic agents and very conjugated aryl acid agents that have very high chemical shifts, very far away from the water signal at 0 ppm. There are also other exogenous agents shown here in light gray. And then there are the endogenous molecules, amides and amines within proteins, glutamate, a metabolite, creatine, another metabolite that's often studied, and glycosaminoglycans in cartilage, and also lactic acid. So we study the aryl amide agents that are in this regime of about 4 to 5 ppm, as shown here, because they have well-known properties for CEST MRI. So one of those properties is to measure tumor pH, particularly the pH in the extracellular tumor microenvironment. The pH in this environment is known to be acidic, less than pH 7, while the internal pH is often 7.1 or higher. And this is caused by the Warburg effect, the upregulation of glycolysis in tumors that drives the production of lactic acid, which is then secreted, or a compensatory mechanism causes neutralization of the internal pH, and that causes extracellular pH to drop as well. Extracellular acid is produced. This is an example of acidoCEST MRI that we have applied to study a tumor model, a mouse with a human tumor in the subcutaneous flank. So it's a relatively non-acidic, mildly acidic model at a pH of 6.9. But if we upregulate the carbonic anhydrase 9 or lactate dehydrogenase A, the pH decreases in these tumors, showing that this truly is showing the effect of the Warburg effect and glycolysis. So we can now track glycolysis metabolism using this CEST MRI method. How does this work in a little more detail? Here is the contrast agent again, known as IsoVu, a clinically approved agent, also known as by its chemical name iopamidol. And if a hydroxide ion comes past the agent, that can remove a hydrogen from the molecule, it gets replaced by another hydrogen atom. And so that causes the chemical exchange to form a water molecule, but really driven by this hydroxide ion. So it is a base catalyzed event. So as pH increases from an acidic to a more basic or alkaline pH value, the chemical exchange rate from this proton will increase. And that's seen in this chart for the proton right here in red, and then also for the proton in blue. The range increases from something that is relatively slow to a more intermediate exchange rate. Now, the CEST effect is ideal at a certain chemical exchange rate, and you can actually have the proton exchange too fast and you will lose the CEST effect. So it's interesting that both of these peaks can be seen in the spectra at different pH, the CEST peaks. However, the peak at 5.6 disappears. It is more difficult to see in the spectrum, while the peak at 4.2 ppm is more present at a lower or at a higher pH. So again, as the pH goes higher, the proton in blue can be seen more. The proton in red actually starts to disappear in terms of its CEST effect. I can take a ratio. In fact, we take a log base 10 ratio of these CEST effects, a rather complex ratio that's very similar to Michaelis-Menten enzyme kinetics theory. And of course, the log base 10 ratio is useful for comparing with pH, which is a log base 10 measurement itself. And we get a linear correlation between the ratio of the CEST effects and the pH. And so that's what we use to measure pH in the tumor. It is difficult to know if we are measuring an accurate value using acidoCEST MRI. The best we can do is insert a microsensor directly into the tumor tissue to measure the pH, but as you can see, the horizontal error bars are quite large here. It is an inaccurate method itself, or an imprecise method, I should say. So because of that, there's no real gold standard to compare acidoCEST MRI to know if we are actually measuring an accurate value. However, it does appear that the best that we can do, a microsensor, agrees well with acidoCEST MRI results. So we're able to measure with very good accuracy and also very good precision. Well, I think molecular imaging is best used for detecting the effects of drugs at the molecular level. However, there are certain cases where molecular imaging can be used for diagnosis, and this is one of those examples. Here's a mouse model with a lung tumor that is acidic, but only mildly acidic. And here's a mouse model that has an infection, coccidioides, which is also known as valley fever. And this is a relatively acidic lesion within the mouse caused by some inflammation as well as the infection. Infections, in fact, are often alkaline, higher than pH 7.4 physiological pH, because bacteria and fungi can produce ammonia and urea that cause alkalinization. So this is the most acidic lesion that we found in the infection model, and this is the least acidic tumor that we found among all these mice with lung tumors that we had developed. And yet you can see that they are very different in their pH, and so it's very easy to tell them apart. In fact, in the entire cohort of animals, you can see that the pH of the infectious disease is significantly higher than the tumor, and a very easy way to distinguish these two types of lesions. For comparison, CT cannot differentiate between a tumor and a infectious disease nodule. That is becoming important as we see residual disease from COVID-19. However, now we have not fully implemented this method for lung imaging in our clinic yet. And if we could, then the uncertainty in CT could be alleviated by doing this molecular imaging method. But as I mentioned, I think acidoCEST MRI and a lot of molecular imaging is best used for detecting the effects of drug therapy. I would not recommend bicarbonate or baking soda as a treatment for cancer, but this is a way of validating that we can change the pH of the tumor and measure that change with acidoCEST MRI. Some tumors in this study had low pH, and after allowing the mouse to drink 200 millimolar of bicarbonate in their drinking water, we saw the pH increase for all of those tumors. Some tumors were not acidic, and their pH was unchanged as expected. In all cases, the bladder became alkalinized, and in fact, we could remove the baking soda from the cage, allow the bladder to return to an acidic pH, and then add the baking soda again to the drinking water and see a reproducible effect. So the bladder and also the kidney and liver and some other organs will become alkalinized. And in some cases, a tumor can be alkalinized, but not in all cases. And this explains why baking soda is not a recommended treatment for tumors. It may or may not work for the tumors, but it will always cause an imbalance in the pH of other important organs, such as the bladder. But again, this is a proof of concept showing that we can treat tumors and watch the pH change. Similarly, we treated tumors with an agent that caused the pH to change in the other direction. A relatively mildly acidic tumor with a pH of approximately 6.9 or maybe even off scale of slightly above 7.0 for some of these pixels was treated with the mitochondrial poison, MIBG. And we had to also administer glucose to keep these mice alive because this was a poison. And this poison would inhibit the function of the mitochondria. So the glucose had to be converted into lactic acid because there was relatively less oxidative phosphorylation, and this lactic acid production caused a severe decrease in the pH of the tumor. So again, we can watch how tumors change in pH when certain drugs are applied. And we can watch the increase or the decrease in pH. So again, in a preclinical model, we inhibited lactate dehydrogenase that inhibits glycolysis. We see a mild increase in pH, and then after we remove after the drug effect wears off, this is only applied for 1 day, we see that the pH returns to a baseline, a somewhat acidic tumor model. We also inhibited mTOR as a way of just generally decreasing the metabolism in the tumor, including glycolysis. And again, we can see an increase in pH, indicating a decrease in the lactic acid production. This effect of the drug then wears off, and we see the pH return to baseline again. In both of these cases, the pH change is relatively small, and so accuracy and precision in measuring pH is important for detecting the effects of these drugs. So we have spent a lot of time being concerned about how to quantify this pH change. As a final example, we used PET MRI, simultaneous PET MRI, to study a tumor model that was treated with metformin. Metformin is an interesting drug with many consequences. One is that it does decrease the mitochondrial function. It also inhibits gluconeogenesis, which is the conversion of lactic acid back into glucose. By inhibiting that process, lactic acid continues to build up in the tumor, and the pH should decrease. And that's what we saw. These solid bars here show the effect of metformin and vehicle applied to the tumor. And the pH decreased from a relatively mildly acidic value to a more acidic value after administering the metformin relative to vehicle. You can see a P of less than 0.05 for the difference between those groups. We also used simultaneous PET MRI to monitor the FDG PET or glucose uptake as measured with SUV max, and that's shown in these lighter bars in front. And we did see a decrease in the glucose uptake in these tumors, indicating an effective treatment. Vehicle also saw a decrease as well, so that was not a statistically significant difference, though. The pH was a better biomarker in this study. So if we were to now switch to clinical acidoCEST MRI, we have translated this method to the clinic. It's about a 30-minute protocol, 23 minutes to actually acquire the CEST data after some initial setup. And we inject the iopamidol, a total of 120 milliliters for about a 6-minute process during the initial part of the scan. And then we collect our CEST data. We collect it before and after injection so that we can do a subtraction to isolate the signal from the agent. Here's a breast image, and we always are able to measure the pH in the retroalar area within the breast. Behind the nipple, there's quite a lot of vasculature, and we can get a lot of agent into this region of the breast, and we measure a relatively neutral pH of approximately 7.2 to 7.4. In a case with a patient with ovarian cancer that had metastasized to the peritoneal cavity, there were actually 3 implants. Here's 1, 2, 3 implants of growing tumor, very aggressive tumor, and the pH was very low, approximately 6.3 on average for these 3 implants. One was particularly low in pH, indicating that aggressive tumors have a lot of lactic acid production, a lot of glycolytic metabolism. So a good opportunity for helping to identify aggressive tumors. For comparison, we also performed a acidoCEST MRI with a patient who had head and neck cancer, a relatively higher pH of approximately 7.0, 6.9 was measured for this tumor. This was a slower growing tumor that had been detected about a year earlier, and this patient was coming for a checkup, and there was no indication of additional tumor growth, a relatively benign tumor that had higher pH. Well, it is possible to perform CEST MRI without a contrast agent. In this case, we're really measuring the protein content within the tumor, particularly the mobile or smallish proteins within the tumor, not larger structural proteins that are immobile. We need mobile proteins that tumble quickly and have a long relaxation time, which allows us to build up this CEST effect. So I'd like to describe the endogenous CEST MRI spectrum, and particularly to focus on the molecular mechanism. So as I've mentioned before, we apply selective radio frequency irradiation at the MR frequency of a proton, an amide proton, that can then exchange with water, causing the selective saturation to be transferred to the water. And that is often known as the amide proton transfer effect because we are transferring this effect from the endogenous amide protons of the protein. We can also apply selective radio frequencies at the chemical shift of an aliphatic CH proton that cannot exchange with water, but through the through space transfer of magnetization known as the NOE effect, the amide proton nearby the carbon hydrogen proton, the aliphatic proton, does also become somewhat saturated. And then through chemical exchange, that saturation can again be passed on to water. And we call this the relayed NOE effect. So you can see that at positive ppm values, particularly about 3.5 ppm relative to water, we can detect the amides. At about minus 3 ppm, we can detect the presence of the aliphatics through this relayed NOE effect. Well, we study the APT effect in our laboratory because we believe it's a more sensitive biomarker of tumor biology. Tumors are known to have higher mobile protein content. So we can measure the amount of protein content using the CEST MRI method. And here's a case of a pelvic mass within a patient who had ovarian cancer, detecting a high level of percent APT. Important point, if I were to come back to the slide just one last time, I would like to again emphasize that CEST MRI is dependent on protein content, the amount of amide protons that are present, and also pH. The amide protons will exchange at a faster rate as the pH increases, just like I described earlier. The protein content dominates the effect in the data, more so than the pH. So endogenous CEST MRI is really measuring protein content and is relatively insensitive to changes in pH, which are rather subtle. and it takes some expertise to really measure the pH of the tumor. It's relatively easy to look at the protein content, and I think that's a point that has been a source of confusion in the literature. So I just wanted to clarify. So if you are interested in performing CEST MRI at your clinical radiology center, I would recommend obtaining a phantom. Here's our breast phantom. We also have a spherical phantom for head coil. We place highly refined gelatin into the phantom that will never mimic tissue exactly, but has very good properties that are pH dependent, concentration dependent, and actually we can change the T1 times of these samples to approximate the T1 of different tissues, and we see the effect of T1 on the CEST data like you would normally see in for tissues as well. So by making this phantom, it facilitates the implementation of CEST at your institution. You can check to make sure that the acquisition and analysis methods are working well. And you can also then calibrate or optimize your saturation power and saturation time in your experiment very easily. So I would strongly recommend a phantom. Again, CEST analysis methods are very important for ensuring that you have good quantitative CEST results. So I've mentioned this MTR asymmetry method. This is just another example comparing the left and right of the spectrum. And you can see that there are two features here in the data, two CEST peaks within the percent CEST spectrum over here. And this happened to be a paramagnetic agent with very, very high saturation frequencies for detection. The Lorentzian line fitting method that we've mentioned is to fit these lines to the spectrum that's shown here. And then finally, we use a block fitting method. The block equations that describe magnetization during an MR experiment can be modified to include the chemical exchange term, and we have further modified that to include pH as a fitting parameter. And the block equations fit the results quite well, while the Lorentzian line shape fitting is really susceptible to noise and doesn't produce the correct pH value nearly as often. So we prefer the fundamental block equations for fitting, which is a very advanced method. This is again to show the two types of methods. But importantly, we did a study with simulations with a lot of random noise added to many types of data sets to show that the block fitting method in blue has relatively good precision, and the Lorentzian line shape method does not, particularly at 7T and high pH, and at 3T at all pH values. The block fitting method is better, and there are intuitive reasons for that. Also, at 3T magnetic field, which is the field that most of us are using for clinical CEST MRI, the block fitting method works okay at 3.5 microtesla, but actually has better performance at 1.5 microtesla, showing that high power is not always needed. Sometimes lower power actually allows the data to be optimized a little bit more. You can see the features in the data with less power. If you're interested in CEST MRI, I would like to mention that the 9th International Workshop will be held on February 14th and 16th of 2022. It will be an in-person meeting at Emory University. Dr. Philip Sun will be organizing and leading this meeting. However, there will be a virtual option for those who are interested in participating and listening in on the meeting virtually. I think that's an important new paradigm within our society, within our scientific society, that now we are becoming more used to having virtual meetings in addition to in-person meetings. And I would like to invite you to attend in either way. I'd also like to thank GE Healthcare, who have been a co-sponsor of the previous workshops in this series, which has been important for furthering the field of CEST MRI. So I would like to switch topics and discuss dynamic contrast enhanced MRI, or DCE MRI. We know that tumors are often angiogenic. Tumors grow chaotically and have tortuous blood vessels that are very leaky compared to normal blood vessels. And this leakiness allows a gadolinium-based MRI contrast agent to leak out of the tumor blood vessel and into the extracellular, extravascular environment. And that can be measured with a K rate going into the tumor and another K rate going back into the blood vessel. And you can see one example here. This happens to be a mouse model, a relatively healthy tumor growing quite well. That takes up a lot of contrast agent after the injection of the gadolinium-based agent. You can see the bladder is also filling up in this picture quite nicely as well. 24 hours after a therapy, an anti-angiogenic therapy, there's actually a hole in the center of the tumor that doesn't take up any agent, and even the periphery doesn't take up much agent at all. And so I think we're all pretty familiar with qualitative DCE MRI. Unfortunately, quantitative DCE MRI, to actually calculate these kinetic transport parameters, has been challenging, and I would like to explain why. Well, one of the major reasons is that we have to identify an arterial input function, or AIF, that identifies how much agent has been injected into the patient, or in this case, into the mouse model. Often a renal artery is taken, or a femoral artery is taken within a mouse. There are other arteries and veins that are taken in patients for this signal. And unfortunately, the signal is often very noisy. There can be potential for motion artifacts as well. You can see the scale is much larger than the scale for my data for the tumor, and the data for the tumor is much less noisy. So the problem is not trying to get accurate and precise image contrast numbers from the dynamic run through the tumor. It's really the arterial input function that is a problem. Well, another major issue, which is often underappreciated, is that large arteries and veins that have a diameter of 70 microns or higher have a hematocrit of about 40%. That would be 40% of the blood volume is occupied by red blood cells within these arteries and veins. And we know through careful measurements done in 1980 and also by Fureyes back in the 1920s, for which this effect is named, that the hematocrit can fall down to as low as 8 to 10% within very tiny blood vessels that are on the order of 10 to 7 microns in diameter, the smallest capillaries within the tumor. So we are overestimating our hematocrit if we assume that all blood vessels are like large arteries and veins within a tumor. And that causes some overestimation of permeability, um, or the overestimate of hematocrit is particularly problematic for small blood vessels that have high permeability. And also, hematocrit is overestimated in hypoxic tumor tissues by definition. And again, those hypoxic tissues may have the highest permeabilities. There's a relationship between hypoxia and angiogenesis, for example. So this leads to the conclusion that tumor tissues with high permeabilities often have this underestimated K-trans transport rate of agent from the blood vessels into the tumor. So we will never get the right answer if we depend on this arterial input function. So instead, others, Tom Yankelov, who is now at the University of Texas in Austin, and also Greg Karsmar, who is at the University of Chicago, they derived the reference region model that uses the contrast agent uptake in the muscle compared to the contrast agent in the tumor. It takes a ratio of these uptakes and therefore does not need the arterial input function. This is a nonlinear fitting method, and I won't go through the math here, but it does take some expertise to do nonlinear data fitting with MATLAB or other programs. So it is more of an advanced technique. Um, and this can be used. However, with the nonlinear fitting method, the fitting is weighted to regions that change quickly, depends on initial guesses, and there's an iterative fitting method. Fitting is slow and sensitive to noise. And you can see this really looks like a very difficult problem. One solution is just to buy better hardware. And certainly that is reasonable, but it is also very expensive to do. Uh, Another alternative is our linear reference region model. We essentially took the nonlinear equations, determined how to linearize the equations, and you can see that if we make a cumulative average of the data in a certain way, that it is nearly a straight line, and we can easily fit a straight line to this data. So equally weighted data, independent of initial guess. This is just like fitting a straight line to a graph. So very low cost, no new hardware is needed. Does this work? Well, yes. We've done many simulations under different conditions of signal to noise and also Temporal resolution, very slow to very fast. Well, if you have ideal data with very fast temporal resolution with excellent signal to noise, you do get the right answer. There's very little error in the estimate of relative K trans relative between tumor and muscle. However, in preclinical imaging, we are typically at 30-second temporal resolution and about a 20 dBA signal to noise. In that case, the linear reference region model performs quite well. The nonlinear reference region model underestimates the kinetic transport rate. And then in the clinic, again, the linear reference region model is better than the nonlinear reference region model. We also looked at precision. Really, it's the initial guess to these iterative nonlinear fitting methods that is causing a major problem. Low values of gauge R&R indicate very good precision. So if you have very good signal to noise, the linear reference region model performs very well. Although, poor signal to noise, it doesn't perform as well. The nonlinear method also improves with signal to noise, but never reaches an ideal situation because the initial guess is often incorrect and therefore leads to problems in the fitting. If we use the initial guess from the linear reference region model calculation and put it into the nonlinear reference region model, which is the ideal guess for nonlinear reference region modeling, then this works. The nonlinear reference region model works. So the key is, again, fitting a straight line to a graph doesn't need an initial guess, and that is a major advantage. We then studied 28 patients with breast cancer of all types, treated with many types of therapies over a range of days by using the Cancer Imaging Archive at the NIH. And this was work from my colleague Julio Cardenas Rodriguez at the University of Arizona. And with our improved precision, we were able to detect a decrease in KEP, which happens to be the transport from the tumor back into the blood vessel, as a biomarker to detect responders versus non-responders. If we saw a significant decrease, then this patient was going to be a responder. And we had excellent results in the study. The nonlinear reference region model clearly has a lot of variability, and we could not detect the responders from the non-responders using this technique. We also recently performed a preclinical study. This happens to be a pancreatic tumor model, but we've tested many breast cancer models in the past. In this case, we applied a drug, or we scanned 2 days before administering a vascular disrupting agent. Then we applied the agent. We imaged exactly 3 hours later because this vascular disrupting agent has very well-known effects on the tumor biology. And then 2 days later, we did a baseline, or we did another scan as well. So there's a lot of data on this slide, but I would just like to point out that at high drug dose, we saw a durable decrease in the relative K-trans measurement using the linear reference region model, and then also to some extent the nonlinear reference region model as well. The TOFS model, the standard model, did not work out very well at all. At a more moderate concentration or dose of drug, we see a temporary effect where vascular perfusion decreases and then rebounds after 2 days. Now we see that with the linear and nonlinear reference region model. Again, the TOFS model really failed here. And then that's compared to no drug at all, which didn't see any effect, and even a very low amount of drug. We saw some response to the drug, but not enough to be statistically significant. So again, these reference region models work, and the linear reference region model is the easiest to perform. So with that, I would like to thank those in my research group who helped with these studies. In particular, Bill Schuler and Jorge de la Cerda were very instrumental in performing a lot of these DCE MRI studies. And the CEST MRI studies were performed by Tian Li and Alyssa Pollard, and also Katerina Katratsu were very helpful in that regard too. And finally, I'd like to thank you for your attention. It's really been a pleasure to present today.